This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified, Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
The best treatment for squamous cell skin cancer is not automatically the biggest operation. It is the least treatment that reliably solves the actual cancer problem. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Right, but if I'm staring at this diagnosis right now, the immediate question is, does my SCC need Mohs, standard excision, scraping, radiation, or medicine? How do I actually figure that out?
Well, to answer that, we're going to follow a specific roadmap today. 1. Determining your tumor's risk. 2. The surgical treatment options. 3. Our mid-explainer risk reset. 4. Non-surgical and advanced options. And 5. Next steps and questions. Let's jump right into part 1, determining your tumor's risk. Because as it turns out, not all SCCs are the same. You know what? It helps to think of risk assessment kind of like a security threat level. Say you've got a small tumor on your back. That's usually lower risk. But if you take that exact same tumor and move it to a tricky spot, like the central face or the ear, that threat level instantly jumps up into a higher risk pathway. Depth is another huge red flag for us. If a tumor invades past 6 millimeters or dips down into the fat, you're suddenly looking at very high risk. We also have to look really closely at the borders and the specific cellular pathology under the microscope. And here's absolutely crucial context. Your immune system holds the trump card. If you're an organ transplant recipient or have certain blood cancers or take chronic immune-modifying therapies, the whole rulebook just changes entirely. To really put into perspective why categorizing this matters so much, let's look at the 5-year disease-specific death rate from a massive study of over 10,000 tumors. For lower-risk tumors, it's a tiny 0.1%. High risk bumps that up to 0.5%. But check this out. Once a tumor hits that very high-risk category, the rate absolutely rockets up to 10.5%. Now, obviously, these numbers are group averages, not individual predictions, but they brilliantly highlight a simple, undeniable fact. Identifying your specific risk level dictates an entirely different battle plan. That brings us to part 2, the surgical treatment options. It's all about matching the method to the margin. When it comes to surgery, the method has to match the margin. Think of it like picking the exact right tool for the job. For a primary, well-defined, lower-risk tumor, standard excision is usually excellent. The surgeon removes the cancer with a planned clinical buffer, often 4 to 6 millimeters, and then pathology checks representative sections a few days later. But what if the borders are blurry? Or if microscopic extension is really likely? Or honestly, if losing healthy tissue on your face is a major concern? That's where Mohs surgery comes in. Mohs actually maps and comprehensively examines the margins during the procedure itself. So it's not really about which surgery is fancier or newer. It's entirely about which tool gives us the margin assessment that perfectly fits the tumor's specific risk. Okay, but can a simpler procedure, like just a scraping, handle this instead of doing a full excision? Actually, sometimes yes. Electrodesiccation and curettage, which is often called scraping and burning, or ED&C, is incredibly fast and effective. But, and this is a big but, it's only for carefully selected, primary, lower-risk tumors in non-hair-bearing areas. Because it uses electrical energy to destroy the base of the tissue, we don't get a perfect margin specimen to check under the microscope afterward. So for deeper, poorly defined, or higher-risk tumors, that simple scrape just isn't going to cut it. All right, let's pause for part 3, the mid-video risk reset. We need a quick shift in perspective.
We need to stop comparing procedure names. First, identify the tumor's risk, and then decide exactly how much margin certainty and tissue preservation the situation requires.
Wait a second, though. If my initial biopsy removed everything I can physically see on my skin, do I actually still need treatment?
Yes, absolutely. You really have to think of a biopsy as just a sneak peek. It's a diagnostic sample. Even if the edges of that tiny little sample look totally clear under our microscope, we literally cannot prove there aren't hidden cancer roots left behind in the surrounding skin. A biopsy margin is just not the same thing as the final, clean margin of a definitive removal. And that is exactly why most invasive SCCs still require active, definitive treatment to ensure it's completely gone.
Moving on to part 4, non-surgical and advanced options. This is for when surgery isn't the primary route.
Now, you might be wondering about prescription creams. Topical or field treatments definitely have a distinct role, but it's almost exclusively for selected SCC in situ. That just means the cancer is superficial and sitting strictly on the very top layer of the skin, the epidermis. These creams are fantastic for that specific use, for sure, but they are not a magical substitute for surgery once a higher-risk cancer has already invaded deeper down.
Then there's radiation therapy. This is a heavyweight cancer treatment, not just some fallback plan. It can actually be a primary option when surgery is declined, physically unfeasible, or would just cause unacceptable functional damage. We might also add it after surgery for tumors with high loco-regional risks, meaning the cancer has started aggressively threatening nearby nerves or lymph nodes. It's an incredibly powerful tool, though it's worth noting there are no randomized head-to-head trials proving one universal cure rate difference between radiation and surgery.
And for highly advanced, regional, or metastatic disease, immunotherapy is fundamentally changing the entire landscape. In recent landmark trials, patients who were given a specific immune-boosting drug called Semiplab after their surgery and radiation saw a massive jump in remaining disease-free after 2 years. We're talking 87.1%, compared to just 64.1% on a placebo. But context is everything here. These specific trials explicitly excluded solid organ transplant recipients and folks with heavy immune suppression. You just cannot automatically assume this works identically for patients whose immune systems are already compromised.
Which brings us to part 5, next steps and questions. Bringing it back to your decision.
When you sit down with your doctor, bring your complete pathology report and ask these exact questions to empower your decision. What specific features make my tumor lower, high, or very high risk? Was my biopsy partial, and do we actually know the true depth and nerve involvement? Exactly how will the peripheral and deep margins be examined? Are there reasons Mohs surgery would add value here, or reasons it's just overkill? And finally, does my immune status change our game plan?
And as a quick note, if you have an organ transplant, a blood cancer, or you're taking immune-modifying therapies, please see the Skin Trust Guide High-Risk SCC in Transplant and Immunosuppressed Patients for specific immune status guidance.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. So the next time you or a loved one are handed a skin cancer diagnosis, ask yourself, are we just treating the label, or are we properly identifying and treating the actual risk?